Welcome everybody to the latest health talks offered by the College of Health Solutions. Our recent health talks have focused, not surprisingly, on COVID-related topics, and this one is no different. We've been planning this particular session for quite some time, and we're incredibly pleased with the two speakers that we have today. And the topic of the session of this health talks is data to decisions, using information to take action during COVID-19. The challenge that we have in society is how do we obtain the best evidence, and then how do we optimize the use of evidence and make the best possible decisions to protect human health. And that movement from science and evidence to practice and policy can take a circuitous route, as we've seen nationwide. And so we're going to explore that some today. The two speakers for today are Dr. Tim Lant, who's a mathematical epidemiologist at Arizona State University. He's an expert in pandemic modeling and response. He spent a good deal of time at NIH doing modeling work. And he's leading the COVID-19 modeling task force at ASU, and he's part of the state's the state of Arizona COVID modeling group. Will Humble is the executive director for the Arizona Public Health Association. He's a dedicated public health expert and has been involved for over 30 years in that capacity. He spent several years actually as the director of the Arizona Department of Health Services from 2009 to 2015. So he very much knows the process by which data is moved into policy and practice. And so we look forward to this presentation to hear some of the up-to-date data from Dr. Lant, and then to hear from Will Humble about the use of those data and sometimes perhaps misuse of the data, and how we can ultimately work to improve population health. My name is Scott Leischow, and I'm a professor of population health in the College of Health Solutions and director for clinical and translational science. I'll be serving as moderator, and after the presentations, we will come back. We want to leave a good bit of time, probably 20 minutes or so at least, for dialogue, for discussion. And so please, if you have questions, please click on the box at the bottom that says Q&A. Don't put it in the chat box. Go to Q&A, post your question there, and we'll see those questions. And at the end of the talks, we'll go through those questions, and I will be presenting them to the speakers. So with that, Dr. Lant, take it away. And we need to put up your slides, I believe, right?
Yeah, great, thanks. So I'm told I can share my screen, so let's hope for another Zoom miracle. All right, so I'm going to give everyone a brief situation update on COVID. I appreciate the invitation to come and talk to this group so much, Scott. It's a pleasure to be here. I'm also very excited about the topic of this session being data-driven decisions. It's something that I've cared very deeply about for, at least the last 20 years. It's something that we're, as a community, as a nation, as a state, we're getting better at, but we still have a long way to go. And the work is hard. So it's nice to have an opportunity to talk a little bit about what we do. And get it in front of this group. And I'm very much looking forward to a question and answer session later with everyone. So let's talk first about the epidemiology of this disease. I'm a mathematical epidemiologist, and what that means is that I have very particular ways that I like looking at data, as any data scientist is going to. So I'm going to show you how I parse through the daily reporting that we have access to. Not to say this is right or wrong or different than any other epidemiologist's approach to looking at this data, but it's nice just to watch and monitor the data on a daily basis so that we really know where we are, and we can think through situations as they unfold in real time. So currently, we've got about 2,300 cases reported today out of 150,000. 8,000 PCR tests reported today with a percent positive rate of 26%. That number is higher than we would like. And then we also track hospitalization and death data. So these are new hospitalizations and new deaths. It's a daily metric. So it gives us just a quick snapshot of what the current incidence of the disease is. I want to back up and take you through some graphics that actually talk about how we got here and what direction are we headed in. Those are a little bit difficult to get from the prior graph, but as we all know, during April and May, during the stay-at-home order, we had a long, somewhat confusing period of constant plateaued growth, where the disease really just wasn't able to get a foothold here. However, when we reopened and a lot of social distancing measures were relaxed, we have the now well-known exponential increase in cases that lasted through July. And now what we're seeing is some interesting signs in the signals where the disease incidence is decreasing. The yellow graph is a 7-day rolling average. So it basically says, how are we doing for the week? And as you can see, the daily data can be pretty dynamic. And so it's hard to read too much from any one signal. But over the last weekly trends, it looks like we've been trending down. The vertical bars are on a 7-day window. So each square is a week. So over the last 2 weeks, it looks like we're having a very nice downward trend in the number of positive cases. And everyone should recall that that's one of the 2 criteria for the White House plan to reopening that's been around for several months now. The PCR positive rate, not as optimistic as the story. The rate went up as we increased testing. We were able to get the rate down. But as disease incidence sparked up again, we see that the percent positive rate continued to increase. And this is clearly because there was an increase in underlying disease in the population and not just a result of increased testing. But you do see that the increase in testing does along with this curve. So what's happening now is that we actually have a little bit of a decline in testing and the curve continues to stay high. And we've seen a bump just within the last week. So we're monitoring this very carefully to figure out whether or not the prevention measures that are in place are going to get this down. And ideally, when we're in the end game on this, we want our positive percent rate to be definitely lower than 5%. Under than 10% would be great for now, but under than 5% under a regime of full contact tracing and isolation for positive cases. Deaths are a different issue. This is what we call a trailing indicator. Deaths go up over time later than the epidemiological curves. And I'll explain a little bit about how this works, but this is a graphic that just shows the deaths that have been reported. Deaths are higher now for 2 reasons. One is that we're at a period of high incidence in the disease, and while it takes a couple of weeks in some instances for individuals to either recover or unfortunately pass away, there's also reporting lags on this data. So what we do to correct this is we look at the epi curves. The epi curves have data that's we try to backfit the data according to when the event happened, whether it's a test, a hospitalization, or a death. There's some nice patterns in here that are worth observing. One is that you see on the last 2 days of each week, you see a decline in the number of positive tests. That's because of the way that tests are conducted. There just simply isn't the volume of tests on those days. And then this line here for the curve, we stop the data right now based on wherever the reporting delay is. And right now there are tests within the system that have a 13-day delay on average. So we're not actually getting any reliable information past this point. But up until that point, the data is pretty good. And we have a couple of mechanisms for dealing with that. Hospitalization is the same. The sign is encouraging because we have a decrease in hospitalization beginning on around June 20th. But we can't say much after the July 7th or 8th. Because the data simply isn't reported yet. So we stopped the data presentation there. And this is not a problem. This is a very known dimension of dealing with epidemiological data, is that there are always delays in reporting and always data that it's impossible to collect, so it ends up being omitted. The death data itself, we have about a month-long delay that we've placed on this one. You can see that the trend was going up pretty significantly. It's dropping now, but it's also dropping in a regime where we can't say anything as final data because the data is still coming in. We have our own local experience here in Arizona. So within Arizona, looking at all of the hospitalizations, fatalities, and infections, we're able to compute the probability that you're going to have a particular, or any individual would have a particular outcome. So the case fatality ratio, which is also the probability of death given that you have a positive confirmed case, is right now in the state of Arizona, it's at 2%. We'd like to see that number below 1.5%. That would be more consistent with national averages. And the thing that that makes that number artificially high is that we're not testing enough. So if we had a larger denominator, we could bring that number down. We also would like to decrease the numerator, the actual death, and we can do that through improved treatments, eventually a vaccine, social distancing, any of the non-pharmaceutical interventions that simply keep transmission down. The green line, the probability of death given hospitalization, is the fact that that's increasing as an indicator that when people go to the hospital, they do get quite sick from this disease, and it's not something that that we can easily dismiss. So hospital usage, we've seen an increase of this. The surge has rolled through basically during the last month of June. In the greater part of July, we've had really escalated COVID hospitalization rates corresponding with people getting sick. And then for the emergency room, this is probably the best leading indicator that we have. You see a steady increase in cases through June and July. When you get towards the end of July, emergency room visits are decreasing. So it seemed like we had a pretty large bolus that went through, and things are stabilizing at this point in terms of ER visits. We also track hospitalization data. I'll spend a little time on this one. The orange bars at the bottom are the number of COVID beds that we have, and these are ICU beds, so intensive care unit beds. Primarily, people are going to be in the intensive care unit if the disease has progressed to a level of seriousness that they require a ventilator or other therapies to enhance oxygen intake, or just seriously ill. So they're highly equipped medical rooms where we can provide advanced care to patients. The gray beyond this are the ICU beds, and the blue are the ICU beds that are occupied but are not COVID-19. So basically, we're squeezing out the available ICU beds either from medical procedures that are not related to COVID. They might be called discretionary or optional, but they're still life-saving in many times. So any procedure that can be scheduled is going to be in one of these blue beds, even if it's a life-saving procedure, chemotherapy or any kind of emergency. And then the gray beds are what's left. You can see that there's, over time, there's a slight increase in the hospital beds themselves due to surge capacity, and you can also see that the COVID beds are actually moving into some of this space where capacity is cleared by releasing other ICU beds. So there's definitely fewer beds that are ICU beds not used for COVID now than there were back in April and May. For inpatient bed usage, you see a similar trend, but there was a peak around the middle of July, around between probably the 10th and the 15th of July, and then those beds start to come down a little bit, which is fantastic to see. And then this one's a little harder. We've got emergency room visits mapped onto the available beds, and what's actually happening is that the emergency room visits, because they don't require a bed, they cycle more frequently, and so you can move 2 or 3 people through that system every day for every one bed. So that's why the graph starts to stick out the bottom to capture that. So key drivers of what we're seeing right now, really in all of the data that I just showed you, it's important to interpret it. So fluctuation in testing volume right now is a major issue. Everyone knows as tests went up, we expected to see more cases. Now we're having a reduction in testing volume, so we would anticipate seeing fewer cases. But there's other dynamics going on too. So we're reporting of lag in cases. So we're seeing 13-day on average reporting delays for cases from some of the testing organizations. There are delays in hospitalization data. It doesn't mean that there's a problem or someone's made a mistake. It just means that these data generally do have some time delay where everything gets filled, QA, QC checked, and then submitted. And then deaths also have a reporting delay because there's multiple reporting systems that have an opportunity to evaluate death certificates for the appropriate cause of death. Test, trace, isolate program, we're not yet capable of detecting outbreak clusters in the state. So we do have nascent nascent programs in order to get tracing and isolation and testing going. The numbers are significant, but the ability to, with pinpoint precision, figure out that someone has a positive test within 24 hours, contact them, get a list of the individuals that may also unknowingly transmit the disease asymptomatically, and see if we can get them a test. Because if we can find those individuals, that's the most promising way to reduce transmission of the disease. And then mask orders are proving effective, coincident with political support at the state and local level, improved public health communication, and our data supports secondary and tertiary effects from perceived seriousness of COVID-19. So this is, as we've moved through this, I think as painful as it was to partially open and then have to partially reclose because our outcomes were moving in the wrong direction, the overall community is seeing that there's a major reason to respond and take this seriously. So one of our collaborators, Dr. Megan Jean, they've produced a survey. And this question is proportion of respondents who wear a mask from March to June. And as you can see, it's gone up from around 25% up to close to 50% in June. We don't have July data yet, but I imagine it's significantly higher than that. Another thing that we have is we've developed a mechanism to fix the reporting delays. So for death data, I told you that there was a delay in this. Based on the reporting data itself and the timing of when it comes in, we're actually able now to cast what we anticipate these curves are going to fill in as. And this is important because the curves always decrease in the final week or two, but it could produce a misleading signal. So as you can see, this curve, the yellow curve now, which is a 7-day average, smooths out our estimates for what this curve is going to fill in as. And you see something consistent with the PCR positive test, which and the hospital data, which is that it does have a peak, and we've come down off of that peak, and we have some nice experience since then. But also there's an opportunity to have a little bit of bump at the end because the first and second day reporting are actually coming in a little higher than we would anticipate. And this probably has to deal with the dynamics of multiple people running tests, multiple organizations running tests, and having different reporting periods. So scenario development, we do run projections. We do use scenarios as a technique to do that. We currently have 3. Each of our scenarios deals primarily with a timeline between the passage of mask orders and significant behavioral changes. Behavioral changes take time to take effect, resulting in delays in when the signal appears in the data. And we take a data-first approach to identify when trends change relative to critical policy and other events. So in general, for COVID-19, it takes about 2 weeks for an event to happen and for us to detect a signal in the data. So when we have an opening and increased transmission because of relaxation of social distancing orders, so we did this over Memorial Day. We did this on the May 15th date when we stopped the stay-at-home order and bars and restaurants were allowed to reopen here in Arizona. It took us about 2 weeks. So it was around the 1st of June that we first picked up on that signal. So now we have several events going on. The masking order is significant. 4th of July was significant. We can't separate these things, but we can look relative to where they are. When does the data tell us that we had a change in transmission? And that's our overall approach here. So again, we still do make projections, and those projections are shared with the Arizona Department of Health Services, and ASU presents those weekly at the Biodesign, the media briefing with Dr. LeBert that happens on Wednesdays. If anyone's interested in that in particular, there's an email address here for you for one of our media relations professionals at the university. And these guys are absolutely fantastic to work with. They're very supportive of everything that we're doing. So compliments to them. Here's our group, a bunch of hardworking people. You know, every one of these people, like a lot of people at ASU, volunteered to do whatever they could, and they just stepped up. So these people have put in, you know, a lot of late nights trying to figure out how we can help and how to use the data in order to inform decision making. So we have a health policy advisor who's a former employee of the Assistant Secretary for Preparedness and Response in HHS and Animal Dune. Heather Ross is on our faculty in the School for the Future of Innovation Society, and she's also a doctor of nursing. As Miguel is a faculty member in the Industrial Engineering Department, and Megan Jean is our chief epidemiologist. So thanks to these guys, and I'm happy to take a few questions or move along and take questions at the end, whatever you prefer, Scott.
Sorry, I was on mute. Why don't we, if there's a, let's go ahead and hold off till after Will's talk. The one question that's been posted so far is, Actually, I'll do the one that was asked because it's a technical question. So the question that was raised was the person is wondering why in the ICU beds graph, there's a temporary drop in the number of total beds between 6.1 and 6.8. Not necessary to answer live, but just looked curious to me. But
Yeah, I would, yeah, so there was a discussion on Twitter between Garrett Archer where he explained the situation. He had just had a conversation with the state health department, and basically they discovered that somehow through their reporting system, through no fault of their own, beds that were surge capacity beds, when they started putting those into the system, they accidentally got tagged with the wrong metadata. So the state was inadvertently reporting ICU beds that were planned beds but didn't exist yet. And it was a pretty innocuous mistake because they also inadvertently posted them as being full. So it didn't show excess capacity that didn't exist, but Garrett Archer with ABC 15 actually helped them spot this, and they corrected it immediately and put out a public statement saying what they did and why. So it was actually a nice moment where the state health department reacted very quickly on a data issue in order to make sure that they communicated in a transparent way with the public. So
excellent, thank you for that, and very good question. Okay, Will, let's go to you.
Thanks, Scott and Tim and everybody for tuning in. So the way I think we could say that Tim did a nice job with like play-by-play, and I'll do color commentary. So I don't have any slides or anything like that, which is the beauty of being the color commentator. And I'll just sort of talk through where I think the critical control points have been throughout this epidemic, and we'll leave hopefully some time for Q&A at the end. So, you know, most of y'all on here have been in public health for a long time, or maybe you're early in your career, but data has always been a cornerstone of public health. And we have always talked about evidence-based public health and the importance of having academic partners, whether you're with a county health department or the state health department, or whatever your role is in public health, in executive public health, county or state level, or some cities have health departments even. It's super important to have academic partners because they're the folks that have the ability to really dive into the data, do the kind of analyses that you need, help you understand what's happening, and in that way inform your decisions so that you're making better decisions. It's such a critical component. Dr. Bob England, who many of you know, has always been an evangelist for this kind of thing. You know, we call it the academic health department. And really, there's no substitute for that kind of analysis because you're not going to find people with the kind of depth and expertise within your state or county health department that you will find in academia. And if you don't use that opportunity to partner with with academics within your state, you're really missing an opportunity to help improve your decision making. And so I've always been, I've always been real enthusiastic about those kinds of partnerships and fostered it whenever I could. Sometimes funded, sometimes you can't fund it, but a lot of times the relationships are what matter the most because everyone's willing to pitch in and help you, even if you don't have some money, if you've got a good relationship with them. So, you know, in public health, we use data all the time. Let me take an example where you would use data and that it's not so, doesn't matter how timely or how, you know, it's not as affected by time. Take WIC data, Women, Infant, and Children program. So one of the, we measure lots of things in the WIC program, everything from BMI to, you know, what parents are choosing with their WIC benefits in terms of how healthy the foods are and so forth. And we track those metrics, and you measure those metrics over the course of, say, a year or 2 years. And so you make your policy decisions and you adjust your policies based on what you learn in the data over the course of an entire year. And timeliness isn't that big a deal because you have time. You have the benefit of time. There are other kinds of epidemics when it's sort of in the middle, where you need that sort of real-time data. You need some analyses in the midterm. And so examples of that are things like, say, when you're dealing with hepatitis C, outbreak of hepatitis C within your community, or sexually transmitted infections like gonorrhea, those kinds of things, syphilis. those are the kinds of illnesses where it's important to do the data tracking, and the timeliness is of moderate importance. You know, you still have time to make policy decisions in the matter of weeks or months, and you could still be effective. But there are other times, like we're living in right now, where you don't have that kind of flexibility. You don't have the benefit of time, because you've got to have the data immediately analyzed and immediately real-time predictive models and so forth in order to help you make effective decisions. And that's the world that we're living in right now, and we will be for the next several months. And so kudos to the partnership team. There's academics at ASU. There's a couple partners at the U of A College of Public Health down in Tucson. I think there may be even some folks from NAU on the local modeling team. But I want to do a real shout out to Rob Bailey at the Arizona Department of Health Services, who early on, really at the very beginning, well, he's always been an enthusiast about, you know, involving academic partners. But from the very beginning of this, he recognized the value and importance of having academic partners to help do the analyses and provide critical data for decision makers throughout COVID-19. And he put together the modeling group. There's an actual word for it. Tim, you could say what that is when your turn comes up again. But it's really the most talented folks in predictive modeling that we have in the state. And it's a group of, I'd say, about 15 folks, all of whom have been volunteering their time to do the real-time analyses of the data, and have been really putting together some tremendous resources for our decision makers to help them think through the implications of their policy decisions and give them various scenarios so that you can look into the future and say, if I do interventions A and B, this is what I can expect to see in the epidemic to look like in 2 months. If I do nothing, this is what I would expect to see. And that's the real value, I think, for predictive modeling, not as a forecasting tool to just, for academic interest, but really as an opportunity to translate that information into actionable knowledge so that people who actually make the decisions about the policy interventions, we'll talk about those in a second, can see what the most talented people in the state think it would look like in 2 months if you made those decisions. And so that's exactly what this modeling team has been doing from the very start. And you can go back to those early documents. Tim talked about that about around before Memorial Day. You guys were doing these in April. I don't think there was any in March. Maybe you could correct me if I'm wrong, but
you were working in March. We were going in March.
Yeah, they were working in March with some of these things, March and April. And the one I remember the most was, I think it was the April report that you came out with, and it's like about a 20-page thing. It's a lot, most of it, I was going to say a lot of it's over my head. Most of the, how we did this part of it is over my head, but what we found part isn't. That was the part that I found super fascinating. And the team put together 5 different scenarios for the benefit of the state health department and for the governor. So scenario 1, 2, 3, 4, and 5. And each of those scenarios were tied to particular policy interventions that could be taken by the governor. And those ranged from things like mask wearing mandates to closing bars and restaurants, the physical distancing, the other mitigation measures, the policy measures, contact tracing effectiveness, turnaround time on the samples. They put all these things together, and Tim, you could talk in more detail about how they create, let's let them call it a beta, which is their predictive diagnostic thing that's super important. But what I want to talk about is how valuable that information was to policymakers had they taken advantage of it. And maybe they did look at that. But it railed through those various scenarios, and it showed you that if you lifted, Tim, I can remember you being quoted in the Arizona Republic in early May when the journalists were asking you what would happen if we end the stay-at-home order on May 15th with the kind of policy decisions that we ended up making. And I wonder if you've even done a graph and like gone back in time and looked at what you predicted versus what the policy showed, the decisions were made. But I can remember you being quoted in the paper saying, the only scenario that doesn't put me back into exponential growth is scenario whatever it was. But essentially what it meant was that you still had to maintain the physical distancing and the policy decisions around the essential businesses and functions that were excluded from the stay-at-home order for a certain amount of time until contact tracing and testing capacity was up to speed, and some of the other components like face mask wearing requirements were put in place. And in fact, I believe what we really did see is policy decisions that reflected one of your scenarios that were predicted within your report that showed us on an exponential growth curve beginning in June and continuing. And that is basically what we saw. And if you look at where the critical control points were with respect to policy and the data that was available that would show you what that policy would lead to, I think you could go back to May 2nd. That was the date where the governor lifted the stay-at-home order with a new executive order that essentially phased out all of the interventions, the stay-at-home order completely until beginning on May 15th. And went to essentially a voluntary system where people were encouraged to follow, businesses were encouraged to follow CDC mitigation measures, et cetera, but without a compliance and enforcement provision within that executive order. And we went on for, as Tim mentioned, we went on for a couple of weeks, and you could look at the data between May 15th and June 1st, and it still looked okay. And it was because of what Tim was saying. There's a lag time for the reporting that, you know, the tests take a while to come back from the laboratory. There's a reporting lag within the, you know, for the new cases and so forth. Same with hospitalizations. Hospitalizations are not real time. You would think a hospitalization is a hospitalization, but that graph fills in over time as well over the course of a week. And so what we saw really was metrics that looked okay up until, I would say, May 26th. And to this moment, I see May 26th is the date when you could see an inflection point in the data that showed that we were going to be on a new trajectory. And the data point that showed me that was on ASU Biodesign Institute's graph that shows new cases divided by total cases by county. And when you look at that graph, you can, it's still up on their website. They're tracking it every day. You can roll back in time and look at that inflection point. It was May 26th. In every single county in Arizona, you saw a decline in the number of new cases divided by total cases. That continued to May 26th. On May 27th, in every single county, it looked like a check mark. The data goes right back up. And by early June, it was actually very quite clear for anybody that was paying attention to the data that was posted up on the Biodesign Institute's website. And by the way, looking at the State Health Department's dashboard, you could see that that information, where we saw the trajectory going, combined with the analyses and the predictive models that were put out by the working group, that we were headed for an exponential growth just as the model predicted. Combine that with just the anecdotal observations that anybody who was paying attention saw over Memorial Day, and the two things make perfect sense because you see the behavior of Arizonans and Arizona businesses around Memorial Day, and you look at what was the data started looking like in early June, and it just became to me quite obvious that that was the moment in time where we had an opportunity to use the predictive models, to use the data from the working group to make some different policy decisions that would have, we would have still had a growth in cases. There's no doubt about that. But I believe that was the point in time where some interventions, had they happened in early June, could have prevented us probably from going to crisis standards of care, which is what happened a few weeks ago. Fortunately, I don't think the hospitals ever had to implement that in a serious or widespread way. But it highlights the two things. Number one, it shows you how little time you have to make decisions when you've got a virus that replicates this quickly. 2 weeks sounds like a long incubation period, but really it's not when you compare it to the other things that we deal with in epidemiology and in public health. It's a really short turnaround time. And so it's the kind of thing where you really have to pay attention to your dashboard and decide things quickly. And these are difficult decisions, and I recognize that. I mean, it's actually quite easy to make these decisions if you don't consider the implications of GDP and unemployment and the other kinds of collateral damage that come with some of these interventions, especially the stay-at-home order.
Hey, Will, I need to jump. You've got just a couple more minutes left.
Okay. So with just a couple minutes left, let me focus on where we are right now and use a contemporary example of how we could use data analytics to help make future decisions. So the question of the day right now, among many questions, is what are we going to do with school openings, especially in the K-12 system? How are we going to make decisions about when to start school and under what circumstances? And I think here again, we have an opportunity to use the modeling team to put together some predictive models that would, for example, run through various scenarios. If, say, for example, that you open schools when your percent positive rate is at 24%, when the trend line for your new cases looks like it does today, when you look at the hospitalization data, et cetera, I think that would be a super useful tool to say, what if we opened up school under the scenario we have today? What would you expect to see 2 months from now? And then put in some additional metrics or scenarios and say, but what if we waited until the percent positive rate was 7.5%? What if we waited until 80% of contact tracing investigations were done within 96 hours before we opened schools? What if we waited until we saw a 7-day moving average decline in new cases over the course of 21 days? And then look at those models to help think through what's a reasonable set of circumstances in which we could start opening the K-12 system. Rather than setting a date, set the conditions under which we would open the K-12 system. And by the way, this model might need to be run 3 ways. One with, say, kindergarten through 6, because we know the epidemiology is very different for kids under 11 years old. Maybe run it for middle schoolers, and then maybe run it for a high school scenario. So I think I'll leave it at that and just say, there were many opportunities to use this kind of information for policymaking in the past. And there will continue to be really important questions to ask between now and February when we're distributing vaccine or thereabouts. So with that, Scott, I'll let it be, and I'll mute myself, and I guess we'll go to Q&A.
Wonderful. Yeah, thank you so much. Really appreciate it. And we've got a number of questions that have been raised, and a few of the topics were kind of referred to. So I'm going to jump around to some of the ones that were asked, and I'll try to specify if this is for one of you or the other or both. And so let me start with one from Dr. Sklar, and it's a pretty broad question, and it kind of starts where you were finishing off, Will. And this is for both of you. So at what point with the data evolving would you feel confident that we could open schools, restaurants, and large population events? Is there one number to follow, like new infections, or is it a combination of presumably new infections, hospitalizations, so on? Will we need to continue to wear masks as we open, and what would happen if we did not require masks? So maybe if both of you could comment on that. start with you, Will, since you started. Why don't you start and then go to Jim?
So the two things that I would look at, well, there were several things I would take a look at. One is new hospitalizations. Because remember, at the very beginning of this, the justification for some of these interventions was to ensure that we had the hospital capacity. Flattening the curve was about maintaining hospital capacity so that people could get the kind of treatment that would be life-saving, and we wouldn't end up like Lombardi, which I think Lombardi was the wake-up call for all of us. So I think looking at the trend in new hospitalizations is one of those. I think as important as that, it would be the 7-day moving average of percent positives, because that gives you it gives you a view into the level of community spread, combined with it gives you a picture about how robust the sampling is. And in order to get from where we are today at about 23% positive over the last week to where we need to be, which is 5% positive, which is where I would argue we should be before we open schools, that would mean that we've got to greatly improve our testing capacity, both timeliness and in the quantity. And so I think I like the percent positive metric along with new hospitalizations. I think those would be my top two. I do like looking at the 7-day moving average of new cases over total cases. That's an interesting metric as well, because it can show you the impact of interventions. I also like the idea, and I have proposed this on my blog over the weekend, is putting in a metric, and it's not on anybody's dashboard right now, but looking at the percentage of new cases that are investigated for contact tracing within the first 96 hours of specimen collection. And I don't think we're there I think probably the percent is 0 right now, because it's taking so long to get samples back from the laboratory. At 13 days, there's no way you can do your contact tracing within 96 hours of that specimen being collected. So I like that metric because it forces the system to correct the shortcomings in the sampling protocol and quantity and timeliness, but also holds the county health departments accountable for following up and at least doing case investigations within the first 4 days. And so those are the metrics that come to mind for me. And so we'll see what Tim says.
Yeah, thanks. Awesome. Tim?
Will makes my job easy. I just have to go get the data now. He's absolutely right. The metrics if well constructed, the metrics will move together as long as we're honest with them and try to make the best measurements that we can. We're working with public health data. There's always bias. We have to consistently deal with it. So I support Will's metrics. We would be splitting hairs if we had a conversation about whether or not testing within 96 hours or 72 hours matters if no one can get a test result for 13 days. So there are now obvious things that need to be done in order to improve our response. And even if we want to have a response, like the response has to be built on a solid foundation, and the solid foundation information needs to be available and processed on a timely basis. I think people will behave responsibly if they have good information, but we're putting people in a situation where 40% of cases are asymptomatic and you get a test and you're not going to get a result for 13 days. And the public health answer is, oh, just stay home. Well, not so much. If you feel fine and you have the choice of making a living to provide for your family or staying home because someone can't get you a test result, I think it's obvious what choice people would make. That's if you can access a test in the first place, and there's still a variety of reasons why that's not possible. But the school question is absolutely fascinating and super important for this disease. I've listened to our politicians talk about moving from a time-based reopening to a condition-based reopening. And I think Will has laid out appropriate metrics for reopening safely. I think that we'll probably not take Will's advice and come up with metrics that are a little bit quicker, because there are pressures on taking a safety-first approach. And there are reasons why it's good for children to be back in school in particular situations. And not all of those reasons are dependent entirely on education. If there are working families and it's a choice between not working and staying home with your kids or putting your kid in school, if the schools can create a safe environment, the kids should go to school, and we should be able to accommodate those in a variety of different ways. And there's CARES funding to do these things. I actually want to ask a slightly different question that we're going to be confronted with in a little while, depending on the choice that we make, because choices do have outcomes, and thinking about the future and making projections means we like to think about these things. What happens if we reopen schools and there are cases that emerge in schools with students, with teachers, students who are in classrooms, teachers who are in break rooms and classrooms, students who will go home and may be living in multi-generational families, or may have parents who don't really necessarily believe that all of the social distancing is required, and their kids probably, gonna catch it, because there is a clear message that kids aren't affected by this disease, so just let them go ahead and get it. I want to know if schools are going to be following CDC guidance, not just for schools, but for the general public, meaning if there's a case that's tested in a school, will we contact trace that case in a manner that's timely? Will we test everyone in their classroom? Will we test everyone they had lunch with? Will we test the teacher? Will we test the other teachers in the break room? And will we close that school down for a recommended 10 to 14 days because it's now unsafe and move to aggressive cleaning procedures? Or will we allow the school to remain open, make it possible for students to get tests and for parents to get tests and teachers to get tests under the current testing environment, and then really just put everyone into the queue where information will be available to you in 13 days. We could have an outright mess in very specific schools with super spreading events. And I think that we need to really carefully think through not just when to reopen, but how are we going to keep the schools safe? And when things start to get a little bit unpleasant, because there will be cases, do we have a system in place that we're confident can address that particular situation and keep everyone safe? Or by virtue of the fact that people are in that school, they're exposed to a level of risk that they don't understand, that no scientist has been able to quantify, and we're just going to plow through it. And that would be, in my view, an irresponsible decision to make.
So great, thank you. Great answers, and let me do some follow-up. And multiple people have asked questions. I'm going to kind of combine some of them in a way, and I'm going to preface it in this way. So, I've worked in government before, as Tim knows and well knows, knows as well. And when I was in the office of secretary, one of the sort of mantras I used to hear in my area in tobacco control was evidence is just one factor in the decision-making process, right? And so this speaks to some of the questions. This kind of speaks to some of the questions that a number of people have raised about whether the modelers, not just you individually, Tim, but sort of this modeling effort, to what extent is it being listened to, from your perspective? Is it being taken seriously? Is it being used, one question asked, how is Dr. Chris, using data and given that there are other considerations, and I know that, that's a potentially awkward question, but I think having a sense of how the science is being considered by policymakers, but then also somebody also asked whether this modeling effort is also being used to guide ASU's decision-making regarding reopening. And so if you could speak to, in whatever level to the degree to which you're comfortable about how the data, how the modeling effort is working or not working.
Right. So I know that Will read my paper, so that's good. At least one person did, or he got cliff notes of it somehow.
Actually, I had to call you and say, "Can you explain this to me?"
There's a really good story here. So first of all, yes, I am very engaged with ASU's reopening plans, and it's a comprehensive plan to reopen. It's not just modeling. It involves testing, tracing, a whole bunch of student programs, really redefining the entire student experience and thinking about faculty and staff and leaning forward to becoming an institution that can deal with, the future realities that they're confronted with. So I'm involved with that. We want to keep students safe. We're going to do a lot to keep students safe. And there's a lot of really cool technology here just through our testing program to do that. So the saliva-based test, I took one yesterday. It took 5 minutes. I'll get a result within 48 hours. The Biodesign Institute saliva-based testing program, which is an asset that Arizona State University will be deploying to make sure that this environment is safe for everyone, is really powerful. Combined with the appropriate notification systems, everyone can stay safe. And we're all gonna have to be careful about it. I mean, Mill Avenue is not gonna be the same next year as it was last year. Going to a football game is not gonna be the same next year as it was last year. So that's reality. We're gonna have to confront that. But what I want to say is, as a modeler, my currency is data and being able to tell stories with data. But there's one and only one reason why I can do this job, and that's because I learned public health. And you don't learn public health from a textbook. You learn public health from getting involved with public health. And that helps me put together models that are better than models from people that don't know public health. They miss the important issues. They don't appropriately address data bias and omitted data and time lags. So they don't have the toolkits in order to do that. And they don't have a vocabulary in order to engage with medical professionals, epidemiologists, public health professionals, nurses, frontline care providers, emergency management. All of these different components of a response, of an epidemiology and infectious disease response, are a vast field and one that has been underfunded, but it's still very good. It's academically challenging as much as any other fields are, both the modeling components and the public health epidemiology components. And I think we've learned that we have an incredible need for people who want to do this kind of work. And as a nation, we need to provide the institutional support and the resources in order to encourage people to come in and do this work together. I got to be a bit of a unicorn because I moved into this field before it existed, and I never anticipated for it to be important in 2020 as opposed to any other year. We went through the 2009 H1N1 response, which was a pussycat of a virus, but it still really stressed out our systems and challenged our ability to make vaccines and communicate public health messages. So we've been laying infrastructure in place for decades at this point. And we're seeing two sides of that. We're seeing the good side and we're seeing the bad side of not using it. What would happen if it wouldn't be there?
So, and let me just kind of continue. So again, in your interactions, and this ties into a question that C.R. Mackey asked. So it's kind of building on the one that I was asked a minute ago. So what have you learned, or have you learned anything new about how to more effectively influence population decisions, behaviors? What is, given this unique experience that you're, as you describe it, and how huge this is, what are the key learnings for you as a scientist, but also in terms of the decision-making processes?
So the first is actually a really cool observation. This is a heck of a lot harder to do at the state and local level than it is to do at the federal level. It's incredibly more difficult, orders of magnitude more difficult to be able to do all of this, have the information, know where the decisions are, being able to move to where the puck is going to be. It's a lot harder and also a lot more rewarding to do this in Arizona, despite the fact that we become a global hotspot and all of the political challenges that we face here. But it's meaningful work because these things are not policy decisions that then happen. These things are the efforts of a lot of volunteers in the state right now who are out, in 115-degree heat, swabbing people in full PPE in parking lots. So I think I've learned what it actually takes at the state and local level, and what the federal government's ability to provide information, models, policies, all of the different supporting services that come down, whether it's through CDC and the Strategic National Stockpile, or HHS ASPR through the National Disaster Medical Services, or FEMA through their data analytics programs or their testing programs. So there's a ton of federal resources, and it's difficult to see and manage all of those from local people unless you're in that environment. And once you're in that environment, sort of, you get a peek behind the curtain. There's the wizard over there, and it's not as all-encompassing and all-knowing. There's a bunch of feds who are also just like us, working really hard to figure stuff out and be helpful. But here's a community of people that care about exactly the same thing. We all have the same goal. Whether or not we've stated it clearly in a way that everyone agrees to and signs off on, that's not actually the point. The point is no one actually wants to get sick and die.
Yeah. So let me turn the last one over to Will, and it's related to this, and as one of the attendees asked this question. So and this really ties in what you're talking about, Tim. Can Dr. Humble provide some context for what Dr. Christ might be experiencing while using data to support the public health case to the governor, who may be viewing this epidemic with other lenses? Seems like public health experts like CDC are being sidelined during the crisis. So, I mean, putting your old hat on there, Will, what's she going through? What are the challenges, and how do you get to the right decision in this challenging environment?
So I'm not going to be able to answer that question point blank, but I could relate my experiences. And
sure,
when you're when you're in a health director job like this, when you're an appointee and report to a governor, so much depends on the personality of your governor. I mean, it just does. And I worked for Governor Brewer. She was my governor, and she had a particular way that she went about business. I really liked working for her. I really did. Her management style and mine really meshed quite well. And I could tell you during H1N1, she wanted to know what was going on. She wanted to know what our recommendations were and why. And she would ask these questions. Sometimes I thought she knew the answer to sort of test us. But it was really a joy to work with her during H1N1 because she was engaged, she was listening, she asked good questions, and at the end asked for our recommendations. And Dr. Bob England, he was running Maricopa County at the time. He and I would be in the room with her and we'd give our recommendations. He doesn't report to her, but she wanted to listen and hear what he thought. And we'd make recommendations, and you know what? That's what we did. And that's how it worked. I mean, really.
But was there much influence from on a national level, kind of pushing a particular agenda that you had to try to, that you perceived there was some, need to abide by?
No, not that I felt. And I don't think, she never said that there was from her perspective. So that was the beginning of President Obama's administration. Secretary Sebelius was in charge of HHS, and before Tom Frieden was the head of the CDC. He didn't come in until 2010, so it was still the guy who was on ABC as the last name started with a B. But so that's how my governor worked. And I worked for Ducey for about 2 months, and then I left. And so I didn't get much of a sense of how he operates. And so the answer to that question really is, it depends on the personality of your governor. And one of the things that I include in my bio about one of the most important things in life is to try to live with emotional intelligence, because if you've got emotional intelligence, you can help read the people that you're working with. And that's the most effective thing. That's the thing that you really need in order to more effectively influence the policymakers at the governor's level.
Okay, and let me stop you there. We run out of time. Thank you both very much. The session was recorded and it will be available if anybody wants to get it. Marissa, do they contact you?
It will be posted to the Health Talks website. So it'll be available there within the next week or so.
Great. I apologize that we weren't able to get to all of the questions. Great questions. You can always send a note to the speakers and ask them directly. But again, thank you so much, Tim. Thank you very much, Will. And thank you to everybody who participated in this session. Please, everybody, continue to be safe. Watch out for friends, family, loved ones, and let's take care of each other. Take care, everybody. Bye-bye.